Thanks, Peter, and it's a real pleasure to speak with you this morning. I'm going to take you from the top where Chris was down to the bottom, to the actual use and what happens in the field. And my career spanned over 30 years with CDC on various assignments, starting, as Peter said, with smallpox eradication. So I'm just going to briefly remind you that the emerging infections that we have today have many different pathways to travel, but they also come from many different animals. And most of the infections we have today come from animals, and they have three major pathways that they can take, as you know. They can end up with no further transmission, rabies being a good example, a viral infection that infects humans but doesn't go further unless there's an organ transplant. They continue transmission for a time and then they stop. Ebola is a good example in the viral area, leptospirosis in the bacterial area. And then finally, there are those that continue transmission and become endemic. HIV, a good example of that, influenza, another good example. So these are the three general pathways that infections can take, and it brings us to the four human coronaviruses that we know about or knew about in past. And those viruses all, as you can see, are thought to have had an animal origin. They now cause the common cold. They're more serious in adults. And early in the pandemic, Mike Watson, who many of you will have known, sent me a reminder to look at an article about human coronavirus OC43, which, as you know, is thought to have come from a bovine species, from cattle, indirectly from bats. And so that study that Mike told me to look at was one which was done by V and his associates, and they looked at all the known human specimens of OC43 from the 50s onwards, the genetic sequence of them as well as genetic sequences in cattle. And they calculated a rate of mutation moving forward, and then they tracked it backwards. And those viruses would have been more or less the same between 1850 and 1890. And what happened in 1889 was the pandemic of what was called Russian flu. And that was a pandemic which had 1 million deaths worldwide in a very small world at that time. And it also had neurological symptoms, which, as you know, are not exactly associated with influenza. So their hypothesis was that this was the emergence of OC43. It emerged as a pandemic, and then it over time became, as population immunity developed, became an endemic infection. And that's been the frame with which I've looked at coronaviruses since then. In 2003, the SARS outbreak, MERS we'll talk about a little bit, and then SARS coronavirus 2. And this is the SARS outbreak in 2003. And what you can see is that it was a limited outbreak. It was a different transmission pattern, as you know. It was deep in the lungs, and it really had to be coughed up in droplets in order to transmit, whereas the coronavirus today is much different. But SARS coronavirus 2 was thought to have emerged from animals sold in live animal markets in China. And this is a raccoon dog, which is thought to have possibly been one of the reservoirs. But what happened during the outbreak and after the outbreak was that the Chinese actually did some investigations. And they knew that 80% of the animals from one market in Guangdong contained levels of antibody to what they thought was SARS coronavirus. And at the same time, they did some studies looking at the market workers, and they saw that market workers had a 13% prevalence of coronavirus infection, whereas from antibody studies, whereas in the community, only 1 to 3% had antibody. But this was never acted on. Neither one of these were acted on, except to make it illegal to sell wild animals in markets, which drove it underground, of course. And then gradually those rules were also relaxed. This shows you what happened in SARS coronavirus 2 early on in Japan when it was understood that this was not influenza. This was a disease which stopped off in communities in outbreaks, and then it went on and spread within the community. And so the Japanese actually did some retrospective contact tracing at their early outbreaks, and they found where these outbreaks were occurring. They not only contacted forward with contacts backwards to find the source, and they found that this is the information that they had, which told them where cases were actually occurring. And they actually did precision-like lockdowns rather than general lockdowns as was done in the UK and most of Europe. In fact, their precision lockdowns were quite effective because when they found transmission occurring in one area, and the same was true in Singapore and Taiwan and South Korea, they immediately locked down those areas. And then when they felt that they had stopped transmission again, they opened them up. Much different approach than was done in Europe and other parts. But early on, we also understood that there was likely airborne transmission of this infection. This is way back in January 2020. You'll remember a bus trip when there were Buddhists who worshiped in a temple in China, were actually on a bus. There were two different buses. One bus had an index case, and as you can see, it transferred to others in that bus. And this was published first as a preprint, and then it was actually finally published. But we knew early on that this looked like transmission. And in March 2020, we also knew that there was airborne transmission. This is a choir that was rehearsing out in the state of Washington when they became infected. But nobody would make these precautionary measures to wear a mask. In fact, WHO, despite of many of the committees, we chaired one, was urging precautionary measures to wear masks early on. WHO would not make wearing masks a recommendation for the general public until they were sure that there was evidence, which never came anyway. So it's just to remind you that we do have research going on. Research outcomes on epidemic and pandemic disease can save lives if rapidly translated into public health action, which hasn't occurred in many situations in the past. Herd immunity was another confusion with the current outbreak, and I won't go through this more to say that the blue at the bottom are those who are immune, and eventually you can stop transmission if you have enough people immune. So herd immunity, the definition, as you know, is the indirect protection of susceptible individuals from infection when a significant portion of the population is immune. And that immunity means that they're immune and protected against infection. At the same time, the threshold is the point at which the proportion of a population that is susceptible falls below the level needed for transmission. And this is the herd immunity graph. Paul Fine and I actually put this together a while back at the London School. And what you can see is that the herd immunity threshold for respiratory diseases such as measles are extremely high. And this shows you that you have to have coverage of up to 95% almost in order to stop transmission of measles, which is what herd immunity concept is all about. Some general concepts of herd immunity that are important to consider, however, though, is if natural infection provides protective immunity against reinfection, herd immunity can occur. And this is a fact which is extremely important to understand because, as you'll see, the modeling didn't take this into account. Strict non-pharmaceutical interventions decrease the ability to create herd immunity from natural infection. And vaccination with long-lasting protection against infection is the most sure way of attaining and sustaining herd immunity. But early on, so constraints in attaining herd immunity for SARS coronavirus 2 was that the immune response after naturally occurring infection, as we know, is not protective against infection in many instances, but it is effective against serious illness and death. And COVID-19 vaccines provide an immune response that does protect against serious illness and death, but not in all cases against infection. So somehow I've lost a few slides, but we'll continue. So population immunity is really the key to keeping SARS coronavirus 2 at bay, and it's not herd immunity as was claimed by many modelers early on. So the keeping SARS coronavirus 2 at bay, the percentage of population that has an immune response is very important. The natural infection and vaccination both contribute to population immunity, and it's measured, as Chris said, by random serological surveys. And this is, as you know, what's happened in the United Kingdom. Vaccination coverage is extremely high, very high. And this shows you the coverage in England, 96% back in July. And what we see is that the infection is being kept at bay, not infection, but serious illness and death as measured by hospital admissions and as measured by deaths. So we can see that population immunity in the United Kingdom is really keeping this at bay. Now, the slide that fell out was a slide of predictions of the threshold of immunity for SARS coronavirus 2 back in March of 2020 that suggested that you could develop herd immunity if you had 75% of the population that had had infection. But this was an assumption based on flu epidemiology and not on the epidemiology that we already knew was occurring with SARS coronavirus 2. So epidemiological modeling is important, and field epidemiologists and modelers must select their parameters closely and together if modeling is to be effective. And there is a Lancet commission just being set up now on how epidemiology can better feed into modeling early on in outbreaks. And that commission will be headed by the HIC-Vac group out in Thailand, but it will include many from Imperial and others around the world. So let's move on then. We've learned so far that research is very important, that modeling needs epidemiological input. This is the SARS outbreak in 2003 that Peter talked about earlier. Remember, this doctor who had been treating an unknown respiratory infection in China to Hong Kong with what he thought was a common cold. But on the way into Hong Kong, he became very seriously ill. And it's thought that he vomited in the hallway. And you can see the red spots where he may have vomited because there were PCR fragments found several weeks after the outbreak began. But what happened in this hotel on his floor was that the people in the rooms in blue became infected, went home, and went back to their various countries, taking the outbreak with them. This is the outbreak, as we talked about earlier. And this is another outbreak, the Ebola outbreak, again, spreading internationally, spreading into Europe and into North America. Fortunately, a very virulent virus that probably could never become endemic, despite the fact that some said it could. But a virus like this with high virulence very seldom can become endemic. Again, we see international spread with COVID-19. And there were many attempts to stop this disease at airports, which was the trend in the past, trying to get people vaccinated for yellow fever and a whole series of activities under what's called the International Health Regulation. But in fact, the only time that the airport screening was really very effective was very early in the outbreak, when you could delay the onset in some countries, and give time for preparation. So we know that borders cannot stop the international spread of infectious diseases, no matter what new technologies are used. Very important concept to remember moving forward. The SARS epidemic. This is the epidemic curve in China, 2002 to 2003. I show you this because it's an example of what classically occurs in outbreaks. Outbreaks occur, and it began sometime in November of 2002. But starting in December, health workers began to get infected. They didn't recognize this as a new infection. They became infected. They drove the infection not only into the hospitals, but into the community through their families. A very important concept to understand, because it happens even in the most advanced countries, such as in Singapore, where index case B infected 10 healthcare workers who then went on to infect a patient and 4 other healthcare workers. So healthcare workers are at the greatest risk of emerging infections, and many times they're the amplifiers of transmission. Now, this disease did not become endemic, SARS coronavirus 1, but in fact, the last human infections were again accidents of healthcare workers. This was in laboratories in Singapore, Taiwan, and China. And finally, other non-respiratory transmission infections are also amplified by transmission in health workers or in poor infection prevention and control, and they then drive outbreaks into patients in the hospital and into the community. Every Ebola outbreak, no matter where or when it occurs, has affected health workers disproportionately and also has spread into communities. And that was true, as we know, with SARS coronavirus 2 as well. So healthcare workers at great risk of infection can inadvertently amplify transmission in healthcare facilities and into communities. And these also cause a surge in patients, as we saw in COVID-19. This is a tent hospital in Italy in March 2020 when they were overwhelmed, as you know, with SARS coronavirus 2 infections. And this is what happens when there's a surge. There's also a delay in treating other patients, and this has been shown clearly in the United Kingdom. It's also been shown through the excess deaths that are reported from other countries, where in addition to the reported deaths from COVID-19, there are deaths that were not expected above that from other causes. So excess deaths are very important in these outbreaks, and that's true also for sub-Saharan Africa, where hospitals collapse when there are Ebola outbreaks. And you can see that in those outbreaks, Ebola is not the major killer. It's those diseases or those incidents which don't get proper management because hospital systems and healthcare has collapsed. And patients with comorbidities, as we know, are at greater risk of severe infection and serious outcomes from infection in SARS coronavirus 2. And this just shows you a comparison of those with underlying health conditions in the US as opposed to those who did not have those infections. So surge capacity is required of the health system as a part of health security measures. And when government planning for disasters or for health emergencies, they have to consider that surge capacity is one of the major things they have to be aware of in order that they continue routine activities. But in addition, making healthy populations because they resist serious outcomes from infections. So we've learned a lot of lessons from epidemics and pandemics. So what's next? And I'll just give you a few ideas because I know you're very interested in vaccines, which are the mainstay of public health. And by the way, vaccines are probably the most effective intervention for antimicrobial resistance. If you can develop bacterial or viral vaccines for infectious diseases, you will prevent the use of antibiotics. And so it's extremely important that that become a part of the agenda, which it isn't today. And anything that you can do will help with that. Ramanan Laxmanarayan and I and Mary Paul Kinney just put a comment in Lancet Infectious Diseases about the importance of vaccines in antimicrobial resistance. But let's go back to, so what's next? Well, this is Zaki, as you know, from Egypt, who was working in Saudi Arabia and first identified SARS MERS coronavirus. He published that on ProMed Mail, the sequence, because he wasn't permitted to report it by the government. And what happened, fortunately, he did that in August of 2012, because in September, as you know, the first case in the UK was admitted to St. Thomas, and it was diagnosed very rapidly as being a new coronavirus. And when the sequence was compared to what Zaki had put out, it was found to be the MERS coronavirus. This had a very, as you know, a very stormy course of disease, and 12 months later, the patient actually on ECMO died. There were some clusters of cases in the UK, but infection prevention and control, as you know, is very good in the UK, and there were no major outbreaks in the UK. But this disease, like all good emerging infections, spread around the world, and it did find where there was improper infection prevention and control in South Korea. And it caused a major outbreak from one importation from Saudi Arabia, killing over 33 people and spreading into 3 different health facilities. We know that camels are carrying this virus. We know that they carry it in the Middle East. We also know that there are camels throughout Eastern Africa that are also carrying the MERS coronavirus in their nasal passages. Yet, we don't yet have a vaccine that is being used in camels to prevent emergence into humans. We know that humans become infected from camels. We believe that they don't cause major community transmission, but they do, in fact, cause some healthcare associated transmission, especially where infection prevention and control is weak. So we've got the understanding of this, but we just don't have the tools yet to deal with this, and we need to. It's endemic in camels in the Middle East and Africa. Occasional human infection, will it cause the next pandemic? And I was just talking with Malik Paris, who many of you will know. I saw him last week in Geneva. And Malik is convinced that this is where we need to be concentrating. We need to be watching that this doesn't cause the next pandemic. But there are other concerns as well. And early in my career, when I was in Africa, one of my assignments was to investigate the cases of human monkeypox that occurred between 1976 and 1981. And I was struck at that time by the visibility of this virus. You'll see there are 2 clades known now. At that time, we only knew that there was a monkeypox virus. And that virus was first identified, as you know, in Copenhagen in monkeys in 1958. In 1970, the first case of human monkeypox was seen in sub-Saharan Africa because they had been freed of smallpox. And they saw this, which looks very much like smallpox. And they thought, we've got smallpox again. And in fact, it turned out to be West Africa. It turned out to be monkeypox. Now, at that time, this Central African clade was occurring not only in DRC, but throughout West Africa. In Ivory Coast, in Cameroon, in many other countries, there were cases as well. 72% of those cases, though, could be traced back to some type of animal contact. Usually it was a young child who had found an animal in the forest, either sick or dead, or played with some type of a small, became infected, went home, and unvaccinated contact household would become infected. But because of the vaccination coverage at that time, 3 generations of transmission maximum occurred in maximum, and they occurred in only 8% of the outbreaks. This is from the database that we collected between 70 and 1980. Case fatality rate was 10%. Facial scarring was present. Primary cases rare over 15 years of age, and most secondary and tertiary infections in unvaccinated parents or siblings. We actually, in 1980, did some serosurveys throughout West Africa and in DRC, looking for antibody to orthopox viruses, because at that time, there wasn't a monkeypox-specific diagnostic test. And we looked in over 15,000 children in 4 different countries and found that they did have a few had antibody to orthopox viruses. Perhaps I think it was 71 of those 15,000 children. And later on, it was shown that some of that was actually monkeypox-specific virus, but these were children who had no facial scars, had no vaccination scar, were not vaccinated, and there was some monkeypox asymptomatic possibly in those children. But then the epidemiology began to change in 1996 to 1999, whereas previously it was rare to see infections in persons under 15 years of age, over 15 years of age. By 1996, 85% of infections were over that age due to waning vaccine immunity. Index cases with animal contact, 72% and 23% in 96 to 99. And you can see that the generations increased, but the case fatality rate remained the same. So the conclusion at that point was that intensified surveillance needed to continue, thinking in the back of all this that possibly smallpox the epidemiological niche left by smallpox would be filled by human monkeypox. And then Annie Rimoyne in 2009 suggested in her studies that there was a 20-fold increase in human monkeypox incidence in DRC. The vaccinated persons had a 5.2-fold lower risk of infection, and improved surveillance and epidemiological analysis was needed. And that's continued, piecemeal, but it's continued. And now we see that countries in Central Africa, DRC, is actually reported between 2009 and 2019, 18,000 suspected cases. But they're unable to confirm these cases because they just don't have the resources necessary to do that. And we've also seen as the age of human monkeypox increases, as vaccination coverage decreases over time. And we see dramatic increases now that we know there are two clades in both clades. We see increases in both the Central African clade, 10% mortality rate, West African clade with a mortality rate much, much less. And this has been a disease which has been neglected in coordinated research and funding. And as a result, we still don't know whether this human monkeypox from the DRC clade, the Central African, what we call now clade 1, will in fact fill the epidemiological niche left by smallpox. If this comes into Europe, it will cause major outbreaks of serious illness. And so we need to be aware of this, and we need to just keep studying. So if we get tired of monkeypox, there are others we can also look at, but we need to keep looking. And we're very fortunate now that BARDA exists. As you know, BARDA is was set up in the US after the anthrax outbreaks in the early 2000s. And it's a multi-billion-dollar fund which supports research for the diseases that are on the US's list of diseases of concern because of bioterrorism. That's why we have an Ebola vaccine, as you know, today. That's why we have a non-replicating smallpox vaccine today, which can be used safely in HIV-infected persons. And we just need to continue our research. And so my final slide, the lessons we've learned from pandemics and epidemics, comes right back to that first thing. We need to continue the research and understand these infections when we can, because when they take off, they cause illness, they cause death, and they cause economic disruption. So thanks very much.